experience. Some years ago, we just reported the first 100 cases of transaxillary small incision technique, but it was a standard technique with over 30 years of experience, so few cases per year, a long-lasting experience. But the technique was well established by a small incision. We did just the resection of the rib, just with help of video assistance, and then it was possible to resect. So this was well established and was effective also in case of seventh cervical rib and pathological fused ribs, with good cosmetic results in this population of young ladies or young men. Then we realized that we could do the same by local and regional anesthesia. And since January 21, we shifted to local regional anesthesia and reported the technique 6 months later, by combining supraclavicular plexus, brachial plexus block under ultrasound guidance with the pectoralis nerve and serratus block. So the combination of these two blocks gave anesthesia to whole shoulder and the axilla, leaving the pathway to resect freely the first rib. And then we were satisfied with this technique, and after the 100 cases, which came quickly in the last 5 years, we collected more than 100 cases, and we decided to make a retrospective study by comparing the general anesthesia group in the usual way with the regional anesthesia group who underwent the intervention with combination of blocks in spontaneous breathing with deep sedation. That was very interesting, because there was no significant difference in the demography. Group was homogeneous, but we never had to convert to general anesthesia. And the interesting thing was that we cut the intraoperative fentanyl. We had no more need of morphine, so these two data are significant. And in the early postoperative period, we had to use the morphine in the general anesthesia group, who experienced pain at awakening, while there was no pain in the local anesthesia because it was covered. From the surgical point of view, we cut by half the surgical time, and we had no lung injuries, which was one of the issues of the previous technique. And patient satisfaction was high, as it witnessed by the increase of number of patients. This is to the first 5 months of 24, and with the fact that almost 1/3 of patients required the second side operation. And so let's have a look. As soon as you open the pleura, the lung collapses, and so goes away. And so you're free to make to free by the electrocautery without any danger to injure the bundle. Now the lump is collapsed, is freed from the posterior, from the superior and inferior aspect. You see the subclavian and the lung here, which is away, and so you can cut without any harm. And you grasp the rig, because there is dangerous that it falls into the thorax, of course, into the pleura, and that's it. So surgical time was quick, was cut by half, and the resection was quicker in the regional anesthesia group, was safer. This was an injured lung in the general anesthesia group. There is no more lung injury, never in the local anesthesia group. So, in conclusion, there was better pain control due to regional block, quicker, easier, and safer surgical technique, and high patient satisfaction. So the limitation of the study is that it was small sample, retrospective, but we are very satisfied with technique, and we go on. Thank you.